Hello everyone. In this edition of Spotters and Boosters 10, I welcome all the students for a good learning experience. Today I'll share the performance of a short note in an examination. One short note given was the statins, and I will discuss in brief how I will perform during examination. Now, the bullets are: what are the drugs called as statins? What is their mechanism of lipid reducing effects? What are the pharmacological characteristics, clinical uses, unwanted effects, and interactions? Now, statins are structural analogues of 3-hydroxy 3-methylglycerol coenzyme A, and this HMG-CoA is a precursor for synthesis of cholesterol. HMG-CoA reductase is an enzyme that converts the HMG-CoA into an intermediate mevalonate that is converted into cholesterol binary. So it is the rate-limiting key step in cholesterol biogenesis. Statins are competitive antagonists or inhibitors of this enzyme HMG-CoA, and they have common hydroxy acid moiety in their structure. And they are called as statins because all names given drugs have suffix statin in them. There are two types. I have divided them into two groups, group 1 and group 2. Group 1 is short acting, so it should be given in evening or at night because steroidal biogenesis occurs maximal at night or midnight, and this group contains lovastatin, fluvastatin, pravastatin, and simvastatin. Among them, the lovastatin and simvastatin are inactive lectins and must be converted into active drug. Some are activated in intestine as beta-hydroxy derivatives. Some are active lectins, pravastatin, and fluvastatin is active by itself. It is not a lectin. Group 2 are active but longer acting, have half-life around 18 to 24 hours, and therefore they can be called as anytime statins. It's not necessary to be given in the evening or at night. Atorvastatin and rosuvastatin have a longer half-life than pitavastatin, which also has approximately 12 hours of life. Now we know the synthesis of lipids and their movement in the body. Intestine and liver play a key role, and adipose tissue has fats which convert them into free fatty acids and go to liver. In liver, there are mechanisms for synthesis of lipids, particularly for uptake and processing. The liver expresses LDL receptors and has ability to take the LDL precursors, which are VLDL and IDL. They go into liver and get converted into the LDL. The LDL output liver also can metabolize LDL through uptake by LDL receptors. Now these things should be known because drugs will be acting some of their. Now in the hepatocyte, cholesterol biogenesis occurs from citrate, and there are many steps, but I have summed them into acetylcholine to HMG-CoA, and from HMG-CoA to mevalonate, and then cholesterol. Now, key HMG-CoA reductase will inhibit conversion of HMG-CoA into mevalonate, so cholesterol will not be formed. There is another drug that inhibits earlier step. ATP cyclase enzyme is inhibited by a newer drug, bempedoic acid, so it has all the effects of HMG-CoA. What are the effects of these drugs on the blood lipids? Statins have a lipid reducing effect and other benefits effects. And other benefit effects are contributory and are called as pleiotropic effects because they are unrelated to lipid reduction. Lipid reducing effects are shown as they are taken up by organic anionic transporter protein into hepatocytes during intrahepatic first passage. Therefore, they get accumulated in the liver. And here they inhibit the conversion of HMG-CoA enzyme to mevalonate, and statins thus inhibit the early rate-limiting step for cholesterol biogenesis. There is a reduced formation of LDL cholesterol and increased expression of LDL receptors that increases LDL cholesterol uptake and catabolism. Statins also reduce LDL cholesterol by enhancing the passage of LDL precursors, IDL and VLDL remnants from blood to liver where they are metabolized. By decreasing hepatic VLDL production, there is a reduced peripheral formation of LDL and cholesterol. And it has been noted that LDL cholesterol reduction is, and depending the dose range for these drugs is shown. For example, atorvastatin 10 to 80 mg roughly half as potent as rosuvastatin 10 to 40 mg. Pitavastatin is the most potent 1 to 4 mg. In these doses, they will produce reduction of total cholesterol, LDL cholesterol, VLDL cholesterol and triglycerides to the tune as shown here, around 20 to 50%. And SDL increases only small, that is 5 to 10% only. Now, in this background, we must understand that treatment dose varies in the form what we say intensity of treatment. Low dose, low intensity treatment is done to achieve a goal LDL cholesterol less than 30% reduction. Moderately high dose is used to achieve between 30 to 50% LDL reduction, and high dose intensive therapy is used to reduce aggressively statin use by a reduction of LDL cholesterol over 50%. And the doses would vary. For achieving moderate intensity or high intensity reductions, we use potent drugs like rosuvastatin, atorvastatin and pitavastatin. And currently it has become the standard practice to initiate high dose statin therapy, that is 40 to 80 mg atorva, immediately after acute coronary syndrome regardless of the lipid reduction. This is because there are added mechanisms that benefit the patient during therapy. Now, maximum lipid reductions occur in about a week, and LDL reduction, as I told you earlier, is log linear and is approximately 6% with each doubling of the dose. If it is, say, a 10% reduction with 10 milligram atorvastatin, it will be 6% more with doubling of the dose. Now, 40 milligram rosuvastatin and 80 milligram atorvastatin maximally reduce LDL by over 50%. But higher doses are avoided to avoid myopathic adverse effect. Cardiovascular risk reduction benefits outweigh lipid-lowering actions, suggesting pleiotropic actions as contributory important actions. In case there is TG elevation, not alone reduced by statin, then fenofibrate, fibric acids or other lipid-lowering agents such as ezetimibe can also be used. Now, pleiotropic effects of the statins are reduced oxidative stress and vascular inflammation, macrophage effect, with increased stability of atherosclerotic plaques. They all contribute for reduction of the events after atherosclerosis. Improved endothelial function, increased nitric oxide production, reduced oxidation of LDL. Oxidized LDL is needed for initiation of atherosclerosis and foam cells. So reduction in the plaque formation occurs. Reduced prenylation of some of the proteins contribute. Details are not given here, but plaque morphology changes. And atherosclerotic plaques are stabilized in aorta. Antithrombotic action has been shown on venous thromboembolism, and this may be contributory whereas decreased prenylization of RAB protein in the brain may reduce accumulation of A beta protein in the neurons. Therefore, there is reduction in the neurodegeneration in Alzheimer's disease experimentally, and there is some clinical. Now, key pharmacokinetic features we must also understand, because it is a short note. Almost variable absorption occurs to the level. The blood levels are achieved variably but are effective. Atorvastatin, simvastatin, lovastatin are metabolized by cytochrome 3A4. So, drugs which induce or inhibit 3A4 may interact with these statins, whereas rosuvastatin, fluvastatin, pitavastatin are metabolized by cytochrome 2C9. And genotype allelics which have reduced function or poor metabolism or enhanced function may alter the metabolism of these statins. Interactions will be with those which are metabolized by cytochrome 2C9 isotype. Pravastatin is not metabolized by a cytochrome pathway, and therefore it is least likely to interact. Therefore, a patient on multiple drugs, one may prefer pravastatin for this reason. About 30% of rosuvastatin, its metabolites are renally excreted. So dose reduction is needed, whereas only less than 2% of active atorvastatin is removed by kidney. Atorvastatin induces its own metabolism by gene translation by acting on the nuclear receptors and making more cytochrome 3A4 enzyme in liver. These features. Now, what are the clinical indications? Primary and secondary hypercholesterolemia, familial or acquired disorders. In primary type, familial hypercholesterolemia 2A, polygenic hypercholesterolemia 2B, and familial combined hypercholesterolemia type 5. Secondary causes are many. Most common are nephrotic syndrome and diabetes, hypothyroidism. Chronic alcoholism, autoimmune disorders are others. Some drugs may also induce metabolic changes, cause metabolic syndrome. Statins reduce cardiovascular events in atherosclerosis significantly, that is, incidence of angina pectoris, acute intermediate syndrome, and occurrence of MI. It also reduces thrombotic stroke and peripheral vascular disease in primary and secondary setting. In primary prevention, ISD in patients with hypertension and other risk factors is reduced by 36%. Risk reduction is proportional to LDL cholesterol reduction. That is why high intense therapy is recommended. Reduction of the stroke risk reduction is also there when LDL cholesterol reduction is required to the level of less than 130 mg/cent. Even then, rosuvastatin is used for primary prevention. Secondary prevention of cardiovascular events in patients who have sustained myocardial infarction and thereafter is given along with antiplatelet therapy to reduce the incidence, that is secondary prevention. And prevention of occurring of MI in patients who are undergoing even non-cardiac surgery. It has been demonstrated. So there is a variety of the causes and underlying factors that will determine use of statin in varying doses. A potential benefit has also been demonstrated in Alzheimer's disease, chronic kidney disease progression, and it is hirsutism due to over. The main adverse reactions are myopathy, which may occur in as much as 25% cases, but usually mild muscle soreness and no life-threatening rhabdomyolysis, which occurs rarely. But this is a dose-dependent predicted toxicity. Myopathy is likely to occur with advancing age, renal disease, hepatic disease, post-operative period, hypothyroidism, and phenotypic variation in the organic anion transporter in the hepatocyte. Hepatotoxicity is not so common, but mild elevations of the enzymes may occur in 1 to 3% cases. Mostly it is asymptomatic, does not require cessation of therapy. It is reversible. Unfortunately, it is unpredictable. When will it recur, it is unknown. A serious hepatotoxicity may occur rarely. hepatic damage occurs very rarely. Now, other effects are high doses increase the risk of developing diabetes, type 2 diabetes. Now, this is an epidemiological study that shows that it must be kept in mind. The question is which other lipid lowering agent is diabetogenic? That is nicotinic acid or niacin. This also greatly increases the risk of diabetes occurrence or worsening of existing diabetes. Adverse interactions occur with statins and niacin, but with statins interaction mostly occurs with the use of gemfibrozil than with other drugs. But we must know those drugs which are metabolized by certain enzymes, for example, CYP3A4. Key interaction gemfibrozil. Now, this fibric acid derivative adds to the lipid lowering effect but exhibits more risk of occurrence of myopathy because it doubles the blood level of statins. Gemfibrozil inhibits hepatic uptake of the statin, therefore remains more in blood, and it competes for the same conjugate enzymes as atorvastatin is there. Now, fenofibrate is preferred to gemfibrozil because it more effective in increasing HDL levels and it is conjugated by an enzyme that is not involved in the statin glucuronidation. So there is less likely to induce myopathy. So remember, dear students, fenofibrate should be combined with a statin, rosuvastatin or now this is all about the short note on statin. Now second short note given was mechanism of action of oral contraceptives. Now as we all know, oral contraceptive is used as a combined pill that contains one estrogen, estradiol, here it is something wrong, and a progestin, norgestin or levonorgestrel. The progestin synergizes with estrogen in inhibiting gonadotropin release. Number sites of the action of oral contraceptives depending on the constituents in it are hypothalamus, pituitary, ovary and genital tract. Remember, ovary becomes smaller and corpus luteum does not develop with continuous exposure of estrogen and the mechanism is depicted here in this pictorial. The feedback inhibition of release of GnRH, which is pulsatile, by progestin and feedback inhibition of FSH and LH occurs with the use of estrogen and progestin together. In addition, progesterone component affects the genital tract and various effects are. The key effect is ovulation inhibition, reduction in the LH and FSH levels, a mid-cycle surge of LHS does not occur, and endogenous E and P levels are diminished and ovulation is inhibited. E and P, as I told you, will synergize and consistently suppress these levels. The inhibition of FSH LH is at the level of pituitary but also through hypothalamus because progestin diminishes the frequency of GnRH pulses that is needed for release of FSH LH, and this is a major progestin action actually. Pituitary, there is a feedback inhibition, so suppression of FSH and LH. Now more important is the effect tract. Transit of sperm, egg and fertilized ovum in genital tract are important contributory to establishing pregnancy. Oral contraceptives affect transport function of fallopian tube by increasing contractions and also increase contraction in the uterus that does not allow establishment of the fertilization implantation and movement of fertilized ovum from fallopian tube downward is there. So actually implantation does not occur. In addition, endometrial changes are not conducive to implantation because endometrium is rendered either in proliferative phase or hypersecretive phase because there is a continuous glandular secretion in luteal phase. Or it may show glandular atrophy, particularly with 19 or progestin derivatives, norethistron, etc. Such endometrium is not ready to receive the fertilized ovum and implantation does not occur. It may actually favor dislodgement of implanted blastocysts, and this particular mechanism for postcoital and emergency contraceptive pill. Cervical changes also occur because of progestin component that produces a thick viscid mucus that blocks the canal, so it reduces sperm penetration. And ovulation inhibition occurs with use of progesterone alone, but it occurs less intensely, that is 60 to 80% in cases by decreasing LH only. Genital effects are more with progesterone, thickening of cervical mucus, endometrial alterations. Copper tea, when used as contraceptive, produces inflammatory reactions. That is the main action for not establishing pregnancy. Morning after pill that mostly contains progestins or combination. They are postcoital and emergency pills. And the proposed mechanism is not actually FSH-LH reduction, but effects on the gamete function, its movement, failure of implantation, dislodgement of the implanted blastocysts, particularly other drugs like mifepristone. Now, these were the two short notes. Now there is a small homework questions which you can find from your books. What is the composition of Mala D? And Mala, remember, Mala N is supplied freely as contraceptive by government. Why ethinyl estradiol is the estrogen of choice, which is combined with progestin in oral contraceptive pill. Third is prescribe an oral contraceptive for female of 35 years of age. Fourth, indication of a higher dose of ethinyl estradiol in place of 30 microgram standard dose. And 5. Which oral contraceptive pill is preferred for women with acne? 6 to 10 are related to statins. Which statin is drug of choice in renal disease? Any lipid lowering drug that reduces lipoprotein A level. Any other drug also reduces lipoprotein A, which is not lipid lowering drug. A drug that inhibits cholesterol synthesis by acting on a step earlier to statins. Name of the drug you have to mention. And the lastly is an oral lipid lowering drug that inhibits formation of VLDL and emphasized by inhibiting triglyceride transfer protein is. So these are the questions you may find the standard books, and if you require you may visit the next episode of Sporters and Booster to find the answers. Thank you.